Hello, Dr. Merck. This is TAMER Sabry, and today I will be discussing pharmacology in mental health practice, focusing on how medication are used to manage several common psychiatric disorders, including anxiety disorder, bipolar disorder, personality disorder, schizophrenia, and trauma related disorder. I will also compare medication treatment with evidence based non pharmacological intervention and conclude with important ethical responsibilities for social workers. The goal is to understand not only which medication are commonly prescribed, but also when alternative therapies may provide equal or better long term outcomes. For an anxiety disorder, selective serotonin reuptake inhibitor or SSRIs such as sertraline and esticabularam and consider first line medication because they increase serotonin level and effectively reduce anxiety symptoms over time. SNRIs included venlafaxine and duloxetine are another first line option, especially when depression or chronic pain occur alongside anxiety. Benzodiazepines like alprazolam and lorazepam provide rapid symptoms relief by enhancing GABA activity, but they should only be used short term because of their potential for tolerance and dependence. Finally, cognitive behavior therapy or CBT is an evidence based alternative that helps patients recognize and change maladaptive thinking pattern responsible for anxiety. For bipolar disorder, mood stabilizer remain the cornerstone of treatment. Lithium is the gold standard because it reduces both manic episode and suicide risk. Anticonvulsant such as valproate and lamotrigine are commonly used when lithium is not appropriate or when patient experience mixed up episodes. A typical antipsychotic including uh, quetiapine and olanzapine are helpful for acute mania and bipolar depression. Medication alone is often insufficient, so interpersonal and social rhythm therapy helps patients maintain a regular sleep and daily routine, reducing relapse and improving long term stability. Unlike many psychiatric illnesses, there are no FDA approved medications specifically for personality disorder. Instead, medication targets specific symptoms. SSRIs may help reduce impulsivity and emotional instability, while mood stabilizers can improve mood liability. Low dose atypical antipsychotic may be useful for patients experience transient sciatic symptoms or severe cognitive disorder. However, the dialectical behavior therapy or DBT remains the gold standard treatment because it teaches emotion regulation, distress tolerance, mindfulness, and interpersonal effectiveness. For schizophrenia, second generation antipsychotic such as risperidone and olanzapine are typically first line because they effectively reduce positive symptoms while causing fewer movement disorder than older medications. First generation antipsychotic remains useful when newer medications are ineffective or unavailable. Clozapine is reserved for treatment resistant schizophrenia due to its superior effectiveness, but requires regular blood monitoring because of the risk of organolepsias. Beyond medications, assertive community treatment provides comprehensive community based support that improves adherence and reduces hospitalization. In trauma related disorder, SSRIs such as sertraline and paroxetine are FDA approved for PTSD and remain first line medications. Vaccine is another effective option due to its dual serotonin and norepinephrine effectives. Prazosin is frequently prescribed to reduce trauma related nightmares and improve sleep quality. However, eye movement desensitizations and reprocessing or EMDR has strong research support and is often as effective as medication in helping patients process traumatic memories while addressing the underlying cause rather than only the symptoms. As a social workers, our responsibilities extend beyond recommending treatments. The NASW Code of Ethics requires us to advocate for equitable access to mental health care, protect vulnerable individuals for unnecessary or expensive medication use, and ensure informed consent. We also have an obligation to challenge barriers that prevent access to quality mental health services and to support policies that promote ethical evidence based care for all populations. Although medications are effective, they have important limitations. SSRIs often require 4 to 6 weeks before patients notice improvement, which can be difficult during periods of severe anxiety. Side effects such as weight gain, sexual dysfunction, sedation, and discontinuation symptoms can reduce adherence. Most importantly, medications primarily treat symptoms rather than underlying psychological factors contributing to anxiety. This highlights the importance of combining medication with psychotherapy whenever appropriate. Research constantly shows that CPT is one of the most effective treatments for an anxiety disorder. CPT teaches patients to identify negative thoughts patterns, gradually confront fears situations through exposure techniques and develop healthier coping strategies. Unlike medications, CBT has no psychological side effects or risk of dependence. Studies also demonstrate that relapse rates are lower after CBT because patients continue using the skills they learn long after therapy ends. The strongest outcomes are generally achieved when CBT is combined with appropriate medications. In conclusion, pharmacological treatment plays an essential role in managing mental health disorders, but medication should rarely be viewed as a stand-alone intervention. Combining evidence based medications with therapies such as CBT, DBT, EMDR, and IBSRT produced